A very good evening to one and all present here. So once, like what Dr. Atik has told about how you are going to plan for a patient who needs a toric IOL or not, the next comes on what type of toric IOL are you going to place in the eye. Because we have each and every company coming and saying that theirs is the best, theirs is easy to calculate and all that. But I would say that it's always up to the doctor to know what a toric IOL, how it is placed, where is the toricity, whether it is anterior, posterior, what types of edges. It's always best to know what type of lens you are planning to implant. So no financial interest. So then we have the monofocal toric IOLs, the multifocal toric IOLs, and also the sulcus fixated toric IOLs in case of no posterior capsule support. So the parameters were, as told, the keratometry, the incision size, the surgical induced astigmatism, anterior and the posterior curvature, which plays an important role, the lens thickness, white to white, horizontal, and the AC depth as well. So in the monofocal toric, you have the toric with blue filter, clear toric IOLs, and the preloaded toric IOLs as well. So the toric with blue filter comes with the Alcon Acrisoft IQ. It is a hydrophobic acrylic material, and it has a aspheric anterior and toric design posterior. So we should all know that which side is the toricity and the size, whether it's 13 mm optical size and the correction of 0.1 minus 0.17. So it goes in 2.2 incisions as well. Every lens has its own unique features. It has its own advantages. So we all know that toric IOLs have these holes, some of them which extend more towards the mid-periphery, so that even if the pupil constricts while operating, you are still able to place it. And some of them have only the three ones which is in the periphery. So by aligning the marks to the steep meridian of the cornea, the lens is designed to address the astigmatism of the patient. So this is the anterior and the posterior surface. And we all have the cylinder plane of IOL plane, and then you have the corneal plane, and you have the recommended range of correction. So each IOL design is also unique, so you need to know how much of correction you want to give for the patient post-operatively, and then decide what type of lens you want to implant. So in this, you have a good range of cylinder correction from -1 diopter to T9 -6 diopters at the IOL plane. Then comes the upper supraphobe toric by the Appaswamy, which is hydrophilic acrylic. It has a 0-degree angulation, and you have a muzzle-shaped hapic, which is used for more stabilization of the lens. And the anterior toric is on the, the aspheric, the toric is on the anterior surface. So here you have the cylinder power and the cylinder power at the corneal plane. You can see the difference, which is very mild, but still when it goes to higher cylinders, you have to make sure that you try to give the patient emmetropia. So the unique features are, these are preloaded, cost effective, and it has a muzzle-shaped hapic design, which helps more better for the lens to stabilize in the bag. And the IOCare has the IOCare EC toric, which is hydrophilic acrylic, and the haptic material is hydrophobic acrylic. So they have a modified C and 0-degree angulation with an SA of -0.018. The optic design is aspheric, and the toricity is on the anterior surface. The total size is around 12.85 with an optic size of 6, and an incision is 2.2 is enough to implant these types of lenses. So we should also know that the difference in the cylinder with the IOL plane and the corneal plane does make a difference for the patient to see post-operatively. So the wide range with a step of 0.5 is there from 1.3 to 6.5 diopters, and it's cost effective as well. These lenses, sometimes you don't have to rotate. The advantage of these IOCare Ultima Smart Toric is you can rotate them on either sides. It's not like once you rotate, you go off the axis, you have to rotate the lens full again 360 degrees. But these plate haptic designs have that advantage where you can rotate either clockwise or anti-clockwise. And some of these myopic patients have a larger eyeball. They also have a larger lens capsule size. So the placement of these lenses in the bag also makes a difference. So sometimes they will also be required to measure the sulcus to sulcus to make sure that what is the size of the lens. So the unique features is white to white is measured for an axial length and the ACD. The formula is used to calculate the capsular bag size. The above three parameters play a crucial role in determining the size of the lens and the effective lens position optimized. And the IOL need to be placed at 0-180. So you don't have to dial these lenses also, they can be placed at 0-180 plane. And then the AMO thickness, you have the toric one single piece lens, which is hydrophobic acrylic, and offset haptic 3-point fixation, and it has a C loop. So the optic design is aspheric, ABC anterior, and the toric is anterior. So this also has a range with a 0.5 step for all diopters and cylinder powers. And the unique features of these lenses are only clear optic hydrophobic toric IOL, and the SA correction is maximum minus 0.27 and has a high Abe number with chromatic aberration where the correction is much better. And then you have the Zeiss toric, which is a hydrophilic acrylic with 25% and hydrophobic surface. It's a plate haptic design with 0-degree angulation, and the SA is minus 0.18. So the unique features are the wide range from minus 10 diopters to plus 32 diopters, and the cylinder you have plus 1 to plus 12 diopters, and the plate haptic which can be rotated on both sides. And you also have these multifocal toric lenses where the patient needs even for reading and for a clear distance vision. So we have the Restore, which comes in actually two different ads. It comes in either plus 3 ad or plus 2.5 ad. So in the plus 3, where the central 3.6 mm is all the diffractive rings, and then the peripheral 2.4 is the refractive. And in the 2.5, you have the central 3.4 millimeter for diffractive and the peripheral 2.6 as the refractive rings. And the only multifocal toric available with near options of 3 or 2.5. So the AMO thickness multifocal toric, so this power range is from plus 5 to plus 34 diopters with increment for 0.5 in spherical. And then you have the corneal plane, you have the astigmatism, and near add of around plus 4 diopters. So this is the Zeiss multifocal toric 909M, which is a diffractive plus 3.75 add at the IOL plane, and it can also go through 1.8 millimeter with a wide range with same 0.05 increments. Why there is so much of IOL in the market, and you will also be confused which one to use. So all the measurements which Dr. Atik has told must be required for all these toric IOLs, even though the company give their own IOL calculator. It's always better to follow like what Dr. Atik said about the Barrett calculator. And the IO Care came with the acryol toric multifocal, the ATM, where the anterior is multifocality and the posterior is for the toricity with a near add of plus 3.25, and the same platform as unifocal acryol EC toric lenses. So all may be similar, but they're not the same. So each IOL is unique. The choice has to be made based on the patient's value, need, IOL power, and the patient's affordability. So we all know that it's no longer a cataract surgery what a patient wants. It's astigmatism free, fast healing, micro incision, laser assisted, no glare, no glasses, 6/6 N6 cataract surgery. So I think after this instruction course, this will what be in our mind also to give the patients. Thank you.